Thank you for the invitation. And happy, not a birthday, it's 13th. We have a World Sepsis Day today, so we have to celebrate. Okay, now, back to the issue. What I really like on this block is it actually puts together things anesthesia can give intensive care. That's important. And I will talk about the topic anesthesia can give us, because there is one strong line. Each of us in this room, sooner or later, will undergo surgery. It's almost given. It's written somewhere. So it's also important for us. So here I'm not talking as intensivist. Now I'll talk as anesthesiologist. That's the anesthesia before we got the volatiles. Sorry, that's the it's a prior volatiles anesthesia. And okay, please let's meet Chris. Okay, Chris is, I don't know, a guy who is doing a lot of jogging, but he can't do anymore because his knee aches. It aches so much that he goes and visits his physician, and because he is not able to jog, he starts to have belly and like conditions. It aches so much that he's going to visit his orthopedician, and the orthopedician tells him that he is in a need of arthroplasty. So he puts him on the list. The list is calling the waiting list, and I don't know how it happens in Hungary. In Czech Republic, this waiting list lasts 1 to 2 years. Usually it's half a year to 2 years. Over that time, Chris is not able to jog anymore. He is waiting. Waiting is such a passive word, you know, we are describing with the good words. So he is waiting. And he is waiting up to the moment when a sort of a list or letter or an invitation SMS comes, which is T-14 or T-30 days. At that moment, everything happens, you know. He has to visit the GP once again. He has to visit the anesthesiologist. The anesthesiologist is very concerned whether Chris is able to pass the surgery in a good fashion, if the heart's fit enough. And then comes the T time. In the T day, he comes to the surgery. There is the anesthetist willing to manage the fitness. There is the orthopedician willing to manage the bone. After the surgery, plus minus 1 to 2 days, Chris is managed by anesthetists or ICU staff or such kind of. So they prefer the heart. And then he goes to the department, usually orthopedics, 3 to 10 days. And after some time, he goes to the rehab facility. And after some time, I don't know, 3 months, 6 months, 12 months, he leaves the hospital. We can say goodbye to Chris. Okay, so that's the way of Chris, okay, from the very beginning to the very end. Honestly speaking, the road is not that straight. It looks more like this, okay? There is a lot of, it looks like this Hobbit journey, I'll say. There's not just the back again. So we can ask, what can we do, what can be done for Chris? And when I think about this as anesthesiologists in Czech Republic, and I believe it will be very similar in Hungary, is that we have to settle the internal preparation, okay, the heart. So there is this must to have a rational optimization of comorbidities, okay, diabetes, normalize, hypertension, normalize. Basically, that's the issue of the preparation. That's what happens, okay. Potentially, we are trying to define some risk factors which can decrease the chances of Chris in passing the surgery. We ask if he is able to go 2 flights of stairs. Okay, as a crude These are the two meds, and it might be enough. We can do more. We can ask for, we can calculate DASI, we can do whatsoever. Basically, we can do in some of those patients not passing 2 flights of stairs, which means he is not fit for meds, which the surgery. We can go for some testing and analyze people who are in low cardiorespiratory fitness. Because these people has a low ability to increase DO2. We've been talking about DO2 yesterday quite a lot, and you see the equation, and I believe all of you know the equation. So the heart's not able to pump more. But that's not the only what happens in there. If you have a low cardiorespiratory fitness, there's also a low ability of you have low mitochondria density. And you are not able to handle the increased O2. So even though you will give the patient dobutamine, even if you will put whatever, blood, dobutamine, and I don't know whatever, if you will put him in hyperbaric oxygen and increase the oxygen diluted in plasma, they won't manage because they don't have mitochondria to handle with. There's another, which is the effectiveness of your lungs. The usual ventilation perfusion index is set down, and there will be ventilatory ineffectiveness in these people. It's coupled with endothelial dysfunction and latent frailty. So this is everything what goes together as a package in those people who have low cardiorespiratory fitness. Okay, but my patient, that's the Chris, okay. My patient's usually not a low CRF patient. I don't know, if you will just ask yourself, if you sit in the anesthesiology ambulance, how frequently you encounter someone who tells you, I'm not able to climb stairs. It's not that rare, but it's definitely not that frequent. And I think it's not anyone in here. But still, if you will, this Chris Pratt, and you will have to choose who is in a better shape than for fighting the evil galaxies, then it's definitely the one on the right side. And if you have someone who is fitter, then the muscle mass has increased his functional capacity, including the respiratory system. So he is definitely better. A frequent exercise increases the metabolic effects. There is a reduce in insulin resistance, fat reduction, and everything. So that's desired effect. It seems that there are immunomodulatory effects, and wound healing after surgery in those who do regular exercise is better than those not doing. Of course, neurocognitive effects. Although all of you who are running, you know what everything happens in your brain when you are running. And of course, improve self-efficiency and decrease the risk of falling, etc. So this everything is actually getting your patient into the shape when he is more prone or more readily able to handle something we call decondition. Because it's happening in the hospital. Just 1 week in the ward decreases your VO2 capacity 5%. Chemotherapy, 10 to 15%. And 1 week in the ICU on respirator is 10 to 40%. So that's what's happening to our patients in the ICU. They are getting deconditioning. And you have to be up to be able to go down under the surface. So basically, when we should talk about something in a PREP, then we have to optimize the patient above normal. Okay, how to do this? So first of all, there's nothing we can do in this time given. Okay, 14 days not enough. Even though we can do in 14 days some miracle, that's not enough. So we have to go back in time to that point where it's possibly a good time to start to get fit for the condition and fit for surgery. Okay, how to do it on an everyday routine? First of all, I will reverse. Again, I don't know how here in Czech Republic what we face is this so-called, well, we call it black box or car service. We know we produce these cars, and there is a famous car, Škoda Plus, which reverses the minuses to pluses. So, nevertheless, we will fix you, okay? Nevertheless, what you bring, we will fix. That's a car service approach of a passive patient. And that's usual patient we face in anesthesia. That's the usual patient we face. He is not responsible for the illness. It just happened to him, out of sudden. I didn't know anything about the illness. The doctor is the expert. I am a recipient of the care, okay? You are here to fix me. And vice versa, also we are there telling them, okay, don't talk about these complications. He may be stressed, post-traumatic stress disorder, post-surgery stress disorder. He might be stressed. Don't tell the family. And there is one more point. Don't speak about any plan B, please. And no plans B. We have plan A. Because complications don't happen, not in this institution. So that's everything. What I will tell, it's a sweet ignorance, okay? Both sides just live in sweet ignorance, and it's great. You don't need information, you don't speak about the comorbidities. Of course, if you wanna have prehabilitation, you have to destroy this. That's something you have to destroy in order to have prehab. Okay, so once you've done this, you can start doing prehabilitation. Prehabilitation step 2 is correct how you, me, or the patient eats. Okay, this is one taken out of the internet, okay? 1 out of 5 surgeons thinks prehab's good. It's literally a group of reasons why to do and fixing nutrition in the patient prior surgery. I have a feeling that's the same saying as in like 100 years ago doctors were smoking Camels. That's the opinion. What we can do and what we should do when we are facing the patient and the pre-anesthesia visit is doing PON score. That's important because that's the one in risk, okay? So doing PON score, just like 2 steps, helps you to see those in risks. So again, that's those who need intervention. For all the others, I'll tell later. Of course, there should be some supplements that's included in, and we know that anemia is a disaster, okay? We know how to fix anemia. What can you do before going to surgery? So what can Chris Pratt do to get to surgery is Mediterranean diet. And I think what's really good today is we get these applications. Each of us is having an application at the table. This may help you to go through the process of fixing your manners, how you eat. And then finally, prehab. So, prehab means you know all the concept of oxygen depth. The oxygen depth is there that you can't handle with the oxygen. And the prehab is nothing else than putting your VO2 peak or an aerobic threshold upwards. So the depth will be smaller. That's everything what's in there. Okay, you get a lot of data that it helps in all these fashions I was just having there in arrows. We know that if you do high intensity, you can fix it in 2 to 8 weeks. So it's possible. And even a slight improvement, if you improve 5%, then you prevented 5% of the conditioning at the end. So that's important. But, you know, if you just see these patients, it might be very difficult for them to do high-intensity training. And it's maybe not necessary. You may have endurance training. Just walk, please. Or if you are better, you go Norwegian. A lot of people are doing Norwegian, and with Norwegian you can do high intensity. And it's never time to stop. You can do rolling. That's brand new. It was published before I came here. The Otago exercise program. Who of you knows about Otago? None. Okay. It's just like this. You just go around the chair each day. Like there is like set of 5 or 6 exercises. They've done this to patients after myocardial infarction. For a year, endurance training. And after the year, all the parameters, first the healthcare parameters, so unplanned hospitalization, cardiovascular death, decreased. But what's more important, much more patients in the intervention group were able to, for self-care and for handling themselves, and were more competent in terms of physical fitness. So, and that's just going around the chair. For us, okay, what you can do. Okay, how to train? So either endurance, which means going every day like the light to moderate. It's just going 10,000 steps or like steps a day. What's better if you want for yourself, do high intensity, which means 2 to 3, 4 intervals and 2 to 3 sessions a week. And again, a lot of you will have this. This is something what may help you to handle it. And if you would like to see the changes, the patient may start to do monitoring VO2 via Apple, via Garmin. All these are monitoring your VO2. So, take-home messages at the final. Pre-surgery preparation starts at the indication. Or better, it starts now because you know that once in your life you will undergo surgery. In my opinion, surgery is like a race, okay? It's not enough to appear at the start, well massaged and do. And smart apps are here to help us to monitor how the patient's going. 2050, we've wrote with Zsolt and Danny Reuter this. We wrote it it was published 2015 or 17 or something like this, 2015, yeah. And we were right, you know. We were, at that moment, we were prophets. Remote preoperative assessment. Okay, we are good, of course. And this was here already. Don't ask what the liver, no, don't ask what the healthcare can do for you. Ask what you can do for your healthcare. Okay, so that's my point of view. Thank you.